We have our next speaker with us, Dr. Sabyasachi Paul, a renowned cardiologist attached to Birla Hospital, who will enrich us about the evidence-based optimization of EMPA-LINA in practice of type 2 diabetes mellitus. And to chair the session, I'd like to invite Dr. Ajay Biswas, the Senior Medical Consultant attached to Kotri Medical Center, and Dr. Guru Prasad Vettacharya, a renowned endocrinologist and one of the backbone of HDS. I would like to invite the chairperson, Dr. Guru Prasad Vettacharya and Dr. Ajay Biswas, and please welcome our speaker.
Good morning, everybody, and welcome to the third session of day 2 of HDS Con 7. Our speaker is Dr. Sabyasachi Paul from the Birla Heart Research Center. He is a very renowned cardiologist and who is slightly sick today with having some throat problems. But despite his physical ailments, he has agreed and made it possible to attend our session. We are very privileged for that. Ajay.
The topic is beyond discussion. It's a very relevant topic, we all understand. Just a couple of points to remember that we've all been talking about early and optimum glycemic control to ensure there is adequate endocrine protection. But unfortunately, the traditional stepwise approach of adding one molecule on top of the one molecule, wasting initial 3 to 6 months on lifestyle modification followed by some time in metformin. Probably the paradigm has changed and more data is coming up that early adoption of combination therapy essentially translates into better organ protection, early intensification or use of a combination therapy in those patients, because you all understand very basic take home point that whatever anti-diabetic agent we are using, we rarely can achieve beyond 1% of A1C reduction. So once our target and the present A1C is beyond that zone, 1.5% or 2% between the present thing, probably we need to consider combination therapy and probably need to look into the molecules characteristic in terms of weight gain or weight loss issues, hypoglycemia risk, and endocrine protection things, and they are probably, these two molecules have categorically shown its ability for protection, cardiac protection, and reduction in all-cause mortality. So definitely this is a very promising combination, and would love to hear Dr. Sabyasachi Paul elaborate with the evidences. Over to Dr. Paul.
Good morning, everybody. Actually, it's an honor to have an opportunity to present in case of descriptive audience. But actually I am very unfortunate that from yesterday I have started fever and upper respiratory infection. And my sore throat is so severe, when I am speaking for a few words, I have a cough. Please pardon me, because there will be some multiple obstruction during the presentation. You are audible. So, there is a multiple of molecules even coming from the diabetes management. But for the diabetes management, nowadays, the treatment of hyperglycemia is not the criteria. Along with the criteria will be to have the mortality benefit. So, though the disease of diabetes is quite age old, the newer molecules which is coming from the treatment should have their evidence from the multiple cardiovascular outcome trial, so that only we can use them. The diabetes is actually the silent disease which does not have any of the manifestations unless it is an advanced stage. So in this group of disease, to convince the patients for the intensification of the treatment from the very beginning, sometimes it becomes challenging for the physicians and the doctors. So When you are going to treat the diabetes, our aim is not only to prevent the hyperglycemia, also to give the cardiovascular benefit to the patients. And today our topic is for the new combined molecules, the M1-LINA, and the evidence that we have in using these molecules in a current practice. So we know that in the diabetes, the multiple of the CV benefit matters in case of CV protections, renal protections, weight loss. And in case of cardiovascular disease, in case of the diabetes, it is a twofold increase in the risk of cardiovascular disease in case of diabetic patients. And there is a multiple of causes of this CV disease, why it is present so early in case of diabetes. And there is a multiple of end-stage problem like arterial stiffness, endothelial dysfunction, oxidative stress, platelet activations, inflammation, metabolic syndrome, and metabolic markers. So, as symptomatic CV disease that is present nearly half of the diabetes patients. So this half of the diabetic patients who having the subclinical cardiovascular disease, if you do not intensify in our treatment, so actually we lose the time for their benefit. You see, in a normal type 2 diabetes patient, they usually having the multiple comorbidities simultaneously from the time of onset. You will get only the 6.4% of the diabetic patients which actually having the only diabetes without any comorbidities. The majority of the diabetic patients either have the more than 2 or more than 3 of the comorbidities, of which hypertension, dyslipidemia is the more prevalent one. So if you delay the intensifications of the treatment, actually you are actually risking the case of MI of 67% and risking the case of heart failure of the 64%. And also 51% there is increase of stroke and cardiovascular events. The molecule that gives the immense cardiovascular benefit is nowadays, it is well known, that is the SGLT2 inhibitors. We know it is a class effect, but out of this, our target is today to discuss about the empagliflozin. In the EMPA, from the different outcome trials, whether it is EMPA reduced or EMPA preserved, when you use the EMPA in case of diabetes, there is a reduction in the clinical risk factor, there is a reductions in the kidney disease, there is 39% reductions in the kidney disease, and there is a reduction, 14% reduction in the CV disease. There is a 35% reductions from hospitalization from heart failure. There is a 11% from all-cause hospitalizations, and 38% reduction in the mortality, and 32% from all-cause mortality. And it is actually similarly depicted in case of EMPA preserved group of patients. And it has been seen when you start the empagliflozin in a patients in case of EMPA reduced trial, the benefits started coming from the as early as 12 days after initiating the molecule. And in case of EMPA preserved, the benefits started coming from the as early as 18 days after the molecule. In case of linagliptin, it did not increase the 3-point MACE, heart failure hospitalizations, and the renal outcome that is depicted in the last Carmelina trial. And there is no increased risk of hospitalization from heart failure that is consistent in the multiple subgroup analysis of the Carmelina. In case of the patients who is having the insulin use, who has the history of heart failure, who has already known case of renal impairment, atherosclerotic vascular disease, elderly, and the different ethnic groups. So, if you combine the patients with the empagliflozin and along with another DPP5 inhibitors, just like linagliptin, we are not increasing the 3-point MACE. Actually, we are decreasing. Actually, we are having the CV death benefit. Actually, we are having the decrease in the heart failure hospitalizations and also the increase in the kidney outcome. But they are individually, they are not very strong anti-hyperglycemic agents. Their HbA1c reduction is respectively 0.8 and 0.7%. And the combined obviously will get more than 1%. they do not have the hypoglycemia unless you are using with a simultaneous metformin, and they are obviously for the SGLT2 inhibitors, they are giving rise to weight reductions and naturally blood pressure reduction. It is not very robust, but yes, 4 to 5 milligram blood pressure reduction is expected in using the SGLT2. There is a multiple real world evidence from the both combinations, and in case of India, there is a COVID time, it has been seen that it gives the definitely benefits. And recently there is a small subgroup analysis, it has shown the empagliflozin decreases the left ventricular muscle mass that still now was only present in the S inhibitor or ARB. So the combine of the EMPA LINA, when you are using in a type 2 diabetes, it is actually reduces the CV disease, heart failure hospitalizations, and naturally we are getting in the guidelines, and where it is written in the class 1 indications to have the SGLT2 to recover the CV disease, and the EMPA is recommended to reduce the risk of death, and for the diabetic treatment to reduce the heart failure, SGLT2 is coming to the class 1 indicator, and DPP4 inhibitor out of this, only the CETA and LINA, it could be considered, it is safe to use, and it is the 2B indication. So, we have the renal evidence and the hepatic evidence. In case of hepatic outcomes and the cardiorena, we have the renal evidence, and we can safely use up to the 30 eGFR. In case of hepatic, there is no dose modification is required in the hepatic impairment in the both EMPA and LINA combinations. And in case of type 2 diabetes, in the non-alcoholic fatty liver disease, EMPA, it significantly reduces the liver fat and improves the SGLT level. So again, it is the same thing, EMPA and LINA combination decreases the 3-point MACE, CV disease, death, heart failure, hospitalization. There is a good amount of renal outcome. It could be given in the hepatic and once daily dosing. So there is a multiple in the comparison between the other existing combination that is present in the market. But actually, it is only thing you can use these molecules in the renal and hepatic patients also. So when you're using the EMPA and LINA combination, it does not impact the cost effectiveness in the long-term management in the type 2 diabetes. Actually, the patient gets the benefit. Now, this is only the single one. How much it is cost effective to using this costly molecule? When the diabetes we are using, there is a multiple related cost in treating the diabetes. The actual cost, 28.3% patients, the cost goes in the treatment of the diabetes, and the 22% goes in to treating its complication. 36% the cost goes in case of monitoring, and 8.7% comes in the other cost. And ultimately the indirect 4% is come the unemployment of the patients, the time he needs this care. So when you're using these costly molecules, actually, though combination is actually cheaper than the individual one, and there is a multiple significant benefit in the 35% in the heart failure hospitalization, 38% in the CV death, 14% albuminuria, and 1.8% in the glycemia better. And also there is a pleiotropic benefit. So when we are having the evidence of the using of these molecules, though the molecule is costly, we also have the potential financial benefit of the patients if you start them very early. Thank you. I am ending this session now. Thank you.
Thanks for the talk despite of your difficult voice condition. It's open for discussion if anyone wants to ask anything. Dr. Kaushal, please.
Well, thank you, Sabyasachi. In spite of your ill health, you have presented a relevant topic Now, one interesting phenomena is combination of SGLT2 with the gliptin, especially linagliptin, reduces the potential side effect, that is urogenital infections. So, can you please enlighten us the biomechanism, how it happens, or although it happens?
It is only decreases the mycotic infections of the SGLT2 inhibitor that increases. In case of linagliptin, it decreases the mycotic. It actually changes the enzymatic problem in case of lina. That decreases the mycotic infection.
I think Shobhusha is having horrible voice condition. With everyone's permission, 3 points we need to remember. First of all, it is not only the reduction of the genital mycotic infection, but also ensuring the durability of glycemic efficacy as well. If I am putting someone on SGLT2 inhibitor, a person starts on peeing more glucose, and such event eventually activates the glucagon axis. To cut that thing, if we combine with the DPP4 inhibitor, whatever DPP4 inhibitor we are using, that will prevent that glucagon axis. So the combination essentially complements each other in that durability of glycemic control point. Second point, as the glucose load is reduced, the blood glucose level is reduced by the incretin activity, so a person pees less glucose. So the risk of genital mycotic infection because of the increased glucose load, that also goes down. Now, specifically for Candida albicans, the fungal mycelium that contains this DPP4 enzyme, and that enzyme blockade by the DPP4 inhibition prevents the fungal mycotic proliferation. So, given these 3 points, there are 2 more points to be understood of this combination. Carmelina study have documented proteinuria reduction quite significantly, but no statistically superior or comparable to the extent of supraphysiological dose of GLP-1 receptor agonist, but definitely there is data for microalbumin reduction. And just one deviation from Dr. Paul's statement, one small statement, he have shown that it is a class effect. Hospitalization for heart failure, that reduction is a class effect. The rest of the spectrum is not class effect. For example, Varticivir study with etugliflozin failed to show any positive outcome from the SGLT2 inhibitor. Remogliflozin doesn't have any CVOT benefit data. So essentially, EMPA and DAPA, they have got positive data. Canvas R and Canvas didn't show any such mortality benefit. Now, if we consider the statistical jargons being a bit complicated and so much debate has been done, there have been a number of publications published in Lancet about the statistical methodology used in Canvas R program. To cut the whole thing short, if you are looking into hardcore mortality endpoint, the dense endpoints, then definitely empagliflozin have shown something, just like the leader study has done with liraglutide. These 2 studies have shown mortality benefit, and definitely that puts empagliflozin out of that. And 4 studies, if we consider both EMPA-REG, EMPEROR, EMPRISE, and the empagliflozin related CKD studies, we can now safely initiate from 25 EGFR, not 30. If already initiated and EGFR drops up to 20, we can continue. Glycemic benefit is not much below the 30, but endocrine protection, be it cardiac or renal protection, that is preserved whatever low dose we are going for. Same way for the DPP4 inhibition, one can say all the incretins are not identical in that aspect. Sitagliptin have categorically shown in TICO study that it stands in the midline, so it is not safe, not unsafe, it's in the midline, so no extra signal. Vildagliptin, pooled data, EMA data, no significant risk factor, but LV mass, there was more LV mass increase with vildagliptin use. Other things, saxagliptin was associated with strong signal of heart failure. Allogliptin, as the name signifies, its allogenic binding to the thing have caused enough immune nonsense, so it is probably not the safe gliptin I will be talking about. Linagliptin slightly less potent in terms of if you are looking for prandial glucose reduction with sitagliptin, but definitely overall A1C reduction between the two are same. There is no p-value difference between the two. And definitely in a country like us where patients drop in follow-up. Suppose someone comes with the AGFR 51 and I am writing full dose of sitagliptin and patient drops in follow-up for next 6 months while his function drops. So sitagliptin requiring 3 tier of dose adjustment from 100 to 50 to 25 depending upon the corresponding AGFRs can have the risk of inappropriate dosing if not adequately monitored. That portion is once again taken care of by linagliptin. That's a convenience factor. That's why probably EMPA and Lina has got something brownies in favor of them. Now they are yet to get off-patented, so they are relatively more expensive. Maybe next year linagliptin will become off-patented, and within a couple of years, maybe EMPA will also join the poor man's basket. So for us, primary caring physicians or intermediate tier physicians, it is definitely promising to accommodate them in our practice. Appreciate this comments.
So it's very well summarized all the thing. One thing I just want to add that yes, with linagliptin, as the glucagon excess is taken care of, and with that the euglycemic decay, that is one possibility of SGLT2, that is also taken care of. The incidence will be reduced. Thank you.
So, Sabyasachi, it has been a nice session. With your painstaking voice, you may. We are now closing the session.
Thank you so much, Speaker. We have a token of appreciation for you on behalf of HDS. And I would like to request our chairperson to please stay with us for the next session.